Hey Group 4, this week's discussion is on the hospital antibiotic stewardship programs. I got in touch with some of our pharmacists at my facility, and currently we do not have one of those. We do have one pharmacist who is in the process of developing and implementing that, but currently we don't have one. As far as definition, it's a hospital-based program dedicated to improving antibiotic use, and what that entails is making sure you have the right antibiotic at the right time for the right duration based on that patient, their disease process, and how they are reacting to that antibiotic. As consumers, the role we play in this program would be more as preventative measures, hand hygiene. When you go to the grocery store or to Walmart, you use the antibacterial wipes they give you. I actually keep a tube of those in my car, and I don't even have kids, but as I think Sarah mentioned, becoming a nurse does make you a little bit of a germaphobe, so I do what I can to protect myself and my husband. And also covering your cough and covering your sneeze. I can't tell you how many times I go out and about and kids and adults, everybody of all ages are sneezing all over everybody, their family, their possessions, everything on the store shelves, and it is disgusting. So it's very important to educate everybody on the importance of covering your cough and covering your sneeze. If you don't sneeze into your elbow, I will sneeze into my shirt, whatever it takes to not contaminate everything around me. As far as our role as healthcare providers, it's very important to use proper PPE when going into these patients' rooms. As far as MRSA, wearing your gown and your gloves, a face mask if it's in their respiratory tract, and C. diff patients wearing your gown and gloves, using the Clorox wipes to wipe down your med carts and your equipment. Typical cavi wipes do not kill C. diff, you have to have the bleach. Hand sanitizer, the foam does not kill C. diff either, so you have to use soap and water. And it's very important to educate the patient and their family the importance of hand hygiene, wearing PPE themselves if they're going to be messing with or dealing with a patient's secretions, bodily fluids, coming into close contact with them, and also washing their hands or using the hand sanitizer when they leave. And that's not only to protect themselves, but that's to protect everybody around them, their families at home. And the same for us. Not only do we have to look out for the patient and look out for ourselves, we have to look out for our family at home. We have the potential to bring home lots of ungodly germs, things that we don't even really want to think about if we don't wear proper PPE and use proper hand hygiene. And let's see, I was on the CDC website that was talking about, let's see which one it was, the core elements of hospital antibiotic stewardship programs. And there's several different factors that go into this program. One thing would be antibiotic timeouts. And at our facility, any positive culture result, whether it's urine, blood culture, whatnot, if it has a positive growth, if it grows gram-negative rods, gram-positive cocci, whatever it may be, it is considered a critical value, and our lab has to call to that floor where that patient is, their room is. They have to talk to the primary nurse and report that value. After that, the primary nurse has to then notify the physician who is taking care of that patient of that value, and that is a great time to review that patient's antibiotics and make sure they're appropriate for what their cultures are growing. We also do multidisciplinary rounds with the nursing, pharmacy, case management, and the primary physician for the patients. That's also a great opportunity to look at what's been growing, has growth progressed over the last few days, how the patient's reacting to the antibiotic. Automatic changes from IV to oral therapy, that takes place in multidisciplinary rounding as well. Our pharmacist will evaluate the patient at the bedside, make suggestions to the physician as to best practice, whether it is time to convert the IV antibiotics to PO, if they're going to be anticipating discharge soon. The sooner you get them on the PO antibiotics, the better, so hopefully they won't have to go home with a PICC line and IV antibiotic infusions. Automatic changes, oh, I just said that one. Dose adjustments Our pharmacy automatically renally doses all of our antibiotics for our patients. Not only do they do antibiotics, they do things like Lovenox for creatinine clearance as well. Dose optimization. Our lab also monitors our patients' white cell counts to make sure they're responding to their antibiotics. They'll do random levels and troughs on all aminoglycosides, your vanc, your gentamicin. And also, it is our job as nurses to look at our patients' lab values. If you know you have a 5 o'clock vanc due and a 4 o'clock vanc trough, it's important to wait for that lab result to come up before you actually administer that medication. Their values could be very low, and your pharmacist is going to have to adjust that dose to a higher dose or a increased frequency. Or if their dose is if their range is very high, they may have to decrease their dose. So it's very important to monitor labs to make sure that you are administering the proper antibiotic as well. Time-sensitive automatic stop orders, that is actually involved with SCIP, the Surgical Care Improvement Project. So in dealing with our joint replacement patients, I'm very familiar with these orders. Our typical antibiotic we choose is NSAID, unless there's a penicillin allergy, and in that case they'll get 3 doses post-op, and all of these must end within 24 hours of surgery end time. Clindamycin, I believe, is the second choice if a patient is allergic to penicillin. In that case, they'll get 4 doses post-op. And then if a patient has a history of MRSA, they'll be on vancomycin. And in that case, they'll get 2 doses post-op at 12 hours apart. Community-acquired pneumonia, one of our protocols at our facility is blood cultures have to be drawn in the emergency room before that patient can be admitted, and they have to be drawn before any antibiotics are given. So when patients come in and the ER physicians are suspecting pneumonia, they'll draw blood cultures and start them on a broad spectrum antibiotic until those cultures actually come back. And at that time they go back to the dose optimization and the antibiotic timeouts to make sure they are getting the appropriate antibiotic at the appropriate dose. And then lastly, Ebola. Ebola is viral, and that's one thing that our whole culture has issues with. It is so hard to wrap your heads around the fact that I have a common cold, I think I need antibiotics. Well, antibiotics aren't going to help a cold. The only antivirals out there really are kind of for flu-like symptoms, and even still, I've seen some research on the news that it may shorten your flu-like symptoms by a day or so, Tamiflu that is. So currently there are no FDA-approved vaccines or medications for Ebola. Ebola, the main thing there will be treating the symptoms and supportive care, maintaining IV fluids, electrolyte balance, maintaining optimal blood pressure, O2 saturations, and then treat any other infections that may have been caused from the disease. I know there's a lot of things in the works, but everything has to go through their clinical trials before they can just take the medications to the hot zones and start trying them out on patients. It's not very fair to those patients to be used as guinea pigs. I'm sure some would probably be willing, but that's not quite how the process works. So I must say I definitely learned a lot with this discussion board post, and I've enjoyed hearing everybody else's. So I hope you enjoy mine, and I look forward to everyone else's.